the most awaited debate, which is on SMILE, Contura, and Zyoptix. To make the session, to give the preamble, I would like to invite Dr. Shri Ganesh, Dr. John Marshall, who is right now the most aesthetically dressed gentleman in the crowd, Dr. Rupal Shah, Dr. Damien Gatinel, Dr. Randleman, and of course we have our grand jurors, Dr. Michael Bellin, Dr. Ramamurthy, and Dr. Sheetal Brar. So if all of us can come in the first front rows. I'd like to invite Dr. Vandana Jain and Dr. Rohit Shetty to moderate the session.
It's a scientific debate. That means there will be some amount of cases being discussed, some amount of plug and play happening. So it's going to be a very interactive one. So, Dr. Gatinel, which side do you want to be in? The SMILE or the Contura side? You can choose, because I was not sure which side you belong to.
Contura.
Rupal madam, I'm hoping you're SMILE.
Yes.
Okay, so we have one for SMILE. Where is
Professor
Dr.
Marshall,
Shri Ganesh?
which one? You want to be a middle one or both, either one of the sides?
I'm a scientist, so I'm always in the middle.
Yes, Vandana, you start with the questions.
So let's start with the side on Contura. Why would you prefer, why are you on Contura side?
Because I have the laser.
Okay, assume you have a SMILE as well. So let's assume that all the panelists, all the speakers who are here have all access to all the machines. So that should not be the answer that I have access only to that machine. You have access to everything that you want to have. So why are you still preferring Contura?
Well, because I'm used to do LASIK surgery, I believe that the concept of correcting corneal aberration is smart, and it provides you with a better, probably, insight of the patient's visual performance. You pay more attention to many details in the treatment flow. So for all these reasons combined, I like it. There are also issues like, the debate between the refractive astigmatism, the corneal astigmatism, which is quite interesting, and it triggers a lot of discussion and interest. So it's also a stimulating treatment for the spirit, and it kills the boredom of a refractive surgery sometimes, so I like it.
Professor Randleman?
Yeah, one thing would be astigmatism management. I think that fine-tuning astigmatism is the ultimate outcome of every refractive surgical procedure, because low amounts of astigmatism have impact on visual quality out of proportion to the amount we measure. And I think that LASIK in general, but topography-guided procedures specifically have an advantage there.
So both of you raised one important point here, as far as the debate is concerned, is you're worried about astigmatism more than anything else. You think that Contura is all about astigmatism perfection, and SMILE you think has not reached that stage of giving you that perfect astigmatic correction. That is the point you need to take up and debate.
Astigmatism with SMILE, if you develop your nomograms and if you do cyclotorsion tracking, the results with SMILE for astigmatism are much better, more stable than LASIK. And this is what I have seen. So now there is a difference in treating astigmatism with an excimer laser and treating astigmatism with SMILE, and you have to understand the mechanics of both. With an excimer laser, you're basically treating the surface area. So if you look at the treatment pattern, the ablation pattern in an excimer laser for myopic astigmatism, it's oval. If you look at the old broad beam lasers, it almost used to become a line if you're treating pure astigmatism. But now it's oval. But Dr. Right? Ganesh, you're treating one side more. But when you look at the pattern in SMILE, the transition zone is just 0.1. It is circular. Because it's not surface area, it is depth. When you're actually excising more tissue and going deeper, what happens is it changes the Gulf-Strand's ratio. And that's why it behaves differently with the rule astigmatism and against the rule astigmatism. With the rule astigmatism, it undercorrects, so you have to have a nomogram of 10 to 15%. Against the rule astigmatism, it does not. So you don't have to, it kind of overcorrects, so you don't have to put in a nomogram.
Dr. Ganesh,
So
I have a question for you.
That's the difference.
I'll have a question for you. I understand you have dissected that machine in and out, and so is ma'am, everything. Say, Prajakta goes to Bombay, and she uses the same concept of what you said. Can she also get exactly the same result as you are doing? I ask if she is doing a Contura, and she goes and does the Contura, say for a -2, and she does a -2, her smile, at her stage of life, can she achieve exactly the same reason like how you're achieving? Is it transmitted?
Yes, it can, she can, if she follows the protocols and the nomograms.
But who gives the protocols? Where is the protocol given? Is it given by Smile?
It is developing, it is a first generation laser. If you should compare Smile to broad beam lasers, because broad beam lasers were first generation excimer lasers, this is Smile first generation. But things are improving, and within a couple of years you will have cyclotorsion tracking, you will have better nomograms, and your results will be definitely better, because the biomechanics, when you say biomechanics,
there's room for one more over here.
Yeah.
So you're making our argument.
When you say biomechanics, you always talk about ectasia, okay? But for me, it's more of long-term stability. Biomechanics means the stability of the cornea, long-term stability of the refractive correction you have done, rather than ectasia, because ectasia, you have done a procedure on an abnormal cornea, and then you get this, whether it's LASIK or a Smile. But if you look at regression and stability over a period of time, and this is the same for astigmatism.
So all this is great, but what we are debating here is, you're talking that Smile is now a first generation laser. But we are saying today, if we have to decide that which platform should Prajakta operate on, then we cannot say that because Smile is first generation, she should borrow nomograms from you and then operate. Can she does that surgery herself today as a Smile surgeon and say that she will get as good a result as Dr. Sri Ganesh, and likewise for Contura when she will operate and she'll get as good a result as Damien?
First of all, Vanna, let's clarify whether we are talking about Contura or we are talking about femtoLASIK or a LASIK in general. Because Contura is not specific for astigmatic correction. We are talking about
you
LASIK,
agree to this?
right?
She said Contura is not specific for astigmatic correction.
Oh, of course it's not. It's
So we are talking about any LASIK, right? Here.
Contura does have a specific role in astigmatism correction. The better the results once we have, there is associated astigmatism when you are talking about Contura.
Yes, but that's
Can I-
more
See,
of a
with-
nomogram adjustment
With
than anything.
Contura, you're basically treating the topography, right?
Yes.
But
So
my
how is
belief is in refractive surgery, you need to treat the refraction rather than the topography, because sometimes you can have corneal astigmatism, but the refraction, the patient accepts only a spherical correction, and I've seen this, because lenticular astigmatism usually corrects the corneal astigmatism. So if you're just treating the cornea and correct corneal astigmatism, you have a residual lenticular astigmatism, and then the patient is unhappy.
Can I just
Yes,
take us
please.
back? The very first slide we had here was Einstein. And Einstein made his name from relativity. And our discussions is really relativity. Just to put everybody in perspective, when we do any form of this surgery, we start with an image, whichever image we prefer, of an intact system. With LASIK, we then cut the top off the intact system and start on a platform which we have no measurements on. With Smile, we actually cut a lenticule out on something now which we have no measurements on. So we're going to do a relative adjustment on a basis which bears no relative relevance in real time to what we're going to do. Just going back to Einstein. Okay, so when you guys discuss this, remember what you're doing here is quite a complex procedure on something which is in some ways experimental. The nearest thing to a clean system is PRK, but we're not going to do that because in PRK we actually start from almost the surface that we measured. So, The point I want to make for both of you is, very good Einstein quote, if you don't know what you're doing, do it neatly and keep good records. Now your records are over a very long period of time. LASIK, and it has shown itself to be in some ways the gold standard. Your records are developing. You have a learning curve which gives you a lot of people coming in that actually give bad data because they haven't moved high enough up the learning curve. So it would be really good now if we discuss this on the basis of data, not ego.
If you just look at the graph at the back.
So just to elaborate Dr. Rohit's question, I think what he was saying is for a young ophthalmologist, now if they have a choice of one machine in their unit, they're starting their refractive practice, they're young, and obviously their first impression should be really good. So would you suggest femto or an excimer platform in terms of correcting, so that you have to look at even the flexibility of treatment also? So what would you suggest?
I think if you turn
laser.
around, you'll see as part of Narayan's answer, this is to reach some level of getting perfection, what we achieve. You need around 150 to 200 eyes where you are extremely good. This is one of our own studies which are unpublished. To reach that stage where you are predictable in quality of vision, where the patient gets you that minimal wow factor on the day one. So do we have to do you get the same thing on your Contura, Dr. Randleman?
So my question, is this the SMILE procedure?
Smile, this is SMILE.
So the interesting thing, if you go back, I'm getting really old, more than 20 years, unfortunately. That hurts a little.
Can you bring the mic a little closer?
Yeah, if you go back a long time, this is the same curve that was published for LASIK in the mid to late 90s. It's interesting. I do think that there have been things done to the LASIK platform that reduce that. I don't know that I've seen data for Contura, but there is a learning curve, certainly.
We agree, all the SMILE surgeons, all of you, me, and all the people here on stage and people off stage, we agree there is a learning curve which is little stronger than the learning curve of a femtolasic.
Rohit, this curve, basically you got the machine and started from scratch.
Yes.
Right? For energy optimization.
Now it is no longer.
But now if you have a machine where you have optimized the energy, where you have nomograms, where you're defined how to dissect the lenticule, then even the first or second surgery which is done is very good. For example,
our laser center in Mumbai is open for other surgeons to come and operate, and we see that they are also getting equally good results.
You agree to this?
For example, I tell you, we have a SMILE training program, and we get surgeons who have never done SMILE, and they do the first cases on SMILE, and the first day visual acuity is 20/20 or better. Okay,
no, I agree with Dr. Ganesh. When I started, I didn't really have a problem. 2 cases Tarak assisted, and I was on my own and never.
You were on your own, so when you're on your own, then the learning curve is steeper.
I didn't have this kind of a learning curve at all. But that could be because I'm already a cornea surgeon to begin with, so dissection was never a.
But still, you need to.
Refractive surgeon. When I started, I had not even seen any flex procedure. I'd seen only a video. And that was a 200 hertz laser with a very sticky surface. And yet we could go on to SMILE from flex within a month.
But to play the devil's advocate from the Contura point of view, I agree that Contura is not about the surgery, it's about the planning. Do you agree? So the problem of learning curve is not the surgery at all for somebody who's done LASIK. The whole of that planning graph actually is like this, exactly the same thing, because there is a huge amount of complex nature of planning. I want all three of you to.
Yes, as you say, it's not like the surgical skill you need, it's more like intellectual process of understanding refractive versus corneal astigmatism, understanding the impact of high order aberrations on maybe the subjective refraction, which is a field of research which is still open. And I think the benefits of Contura are also very importantly because pupil centration toward the apex, you know, like custom centration and cyclorotation compensation. In many astigmatic eyes, there is a large kappa angle, and you need to take this into consideration for the centration of the surgery.
So what do you do with the smile? What exactly what you mentioned?
Smile centers on the visual axis because the patient is fixating on the fixation light, and as you, but it is good to know the landmarks, and Dan Reinstein also has defined this as to how he uses the atlas, marks the angle kappa, that's the visual axis, to the pupillary axis, and has a reference. So when he's docking, he can refer to that. It is a surgeon-based centering, which is very important in smile, rather than a machine-based centering, which happens
Also,
in Contoura. It's automated, but over a period of time, maybe in a few years, you would have some kind of an automated centration.
Also, for most myopes, the angle is not that significant. And to answer your question, if somebody is going to be starting afresh, they should invest in a femtosecond laser because that would really enhance the safety profile. And if your femtosecond laser can do both a flap as well as a smile procedure, it gives you an added advantage. That's why I would buy a laser which can do both type of procedures. Topo linking has been available since more than 10 years now on an excimer laser platform. So you could use those for those occasional patients who need their topographies to be adjusted. In most virgin eyes, the topographies are pretty smooth. You don't know what you are smoothing out there because you don't know what is going to work, what is not going to work with the neural adaptation already in place, with that irregularity in place. So I don't know whether I would really want to make it aberration free, so to say, and make a patient unhappy without understanding what's happening.
I think this side
so
is
you're suggesting
less
femto platform instead of an excimer platform.
See, if you buy an excimer platform, you have to buy a femto second laser also for a flap, unless you're using a microkeratome. Unless you're using a microkeratome to do LASIK, you have to buy a femto and an excimer.
That's the thing. I think majority of the small clinics have one machine, and I think so many of them have not upgraded to a femto.
But with Contura also, if you're going to make your flap with a microkeratome,
a femtosecond laser.
So
you are inducing more aberration.
So to specifically address Narayan's question, I think if you have to, youngster has to buy a single equipment, it has to be an excimer laser. Simply because femto, the smile platform doesn't address all the needs in the sense that you can't do a topo-guided treatment, mixed astigmatism is not possible, as of now hyperopia is not possible. Definitely, of course, it has to be done with a microkeratome. We are talking about a youngster starting out with a practice, which is cheaper investment. I'm standing in the middle more because I'm equally comfortable with both smile and femto LASIK. I think they're very good platforms. Smile has the advantage in the sense it resonates with all of us, in the sense that it's flapless, and all the flap-related complications are gone off. As regards the other advantages that is being talked about less of dryness, better biomechanical stability, faster, slower recovery, etc. These depends on whose paper you are reading and who's presenting.
I'll ask him a question.
Really,
for all the literature review you have done from your journals,
Yes.
which has both sides, which has given, which looks at both sides of it, being editor of JRS. Can you answer this question? Does LASIK have better visual quality than Smile? Because we have both versions.
Well, I think it depends. The next line needs to be at a certain time point. I think it definitely does early. Later, in patients who were good candidates for both, I don't see much difference. Again, in higher amounts of astigmatism, the literature suggests that LASIK is still superior there.
So is there a meta-analysis kind of a work being done, paper being presented on?
Well, I'm not aware of it. The problem is that the numbers are so dramatically different in terms of what's available with LASIK outcomes versus Smile outcomes that it's not that equivalent yet, especially if you're starting to look at something like astigmatism correction, which has only been available more recently.
I think that's a crucial point, time. We're back to relativity again. LASIK has been here for longer. The algorithms have improved and improved and improved, and to some extent we know the long-term outcome. Smile has only been here for a small time. The algorithms are getting better. We don't know the long term. The biomechanical measurements would suggest that it is slightly more stable than LASIK, but only slightly, because you're still cutting a lot of those, about 200 million collagen fibrils with both techniques.
Yeah.
But you get an intact ring with Smile that you lose with the LASIK flap. But Brad is absolutely right. It's time dependent, so this is almost an impossible decision for you guys to make. And I'm really quite worried that the Smile group have now moved over to the LASIK group.
So I would put my money on the predictability and the stability that Smile has to offer.
But both of you been doing it
and
for the
not
longest
for
duration.
anything else.
Do you agree with Brad that it takes time, over time, to get you the same visual outcome? Because you use virtually a lot of platforms, including Zyoptix, which we are going to discuss, that it takes time.
There's also like a crucial point for astigmatism correction, is that when you do astigmatism correction, studies show that there are increased risk of enhancement. And to me, the major issue, this is why I'm not really pro-Smile in my practice, is that it's quite difficult to do enhancement. At least you have to switch to PRK or do circle treatments. Whereas I think paradox is that in LASIK, the best ally of the surgeon is a flap, because even 20 years later on, when your patient comes back and has become presbyopic, you can propose a monovision by lifting the flap, or if myopia progresses over time, you can retreat really comfortably. And that's, to me, the most important factor for favoring LASIK over Smile is the retreatment rate.
What percentage of patients go for retreatment in your practice?
I mean, when they have astigmatism, it's way higher, I would say, like 10% of the odds are 10% versus 2-3%
This
for
is
regular
Contura
treatment.
patients.
Huh?
This is Contura.
Whatever astigmatism strategy you have to use, the chances are that you will have an increased risk of retreatment, because the astigmatism represents more constraints in terms of alignment, geometry of the correction, etc. So the chances are you will have to do more enhancement in that population, and LASIK is clearly the technique with which the enhancements are easier to perform.
I think we'll ask an audience question here. How many of you do enhancement? Yes.
I think your debate has been specifically mentioned as Smile versus Contura, not Smile versus femtolasic. And just like we talked about a learning curve for Smile in the procedure, Contura is there's significant learning curve as far as getting the data is concerned. I know you feed the wrong data, you get suboptimal outcomes. And actually, still we are not very clear as to what data is to be used. Initially, it was just wavefront optimized plus a topo-guided treatment. Then we thought about doing a TMR, this topo-guided manifest refraction. It just did not work out. Then we started using half the values. Again, the results were plus minus. Now we are talking about something called 4CDs. And that seems to be very promising, and we have done some initial cases, but it's working well. Now, having said that, I mean, if you're talking about Contura, it's not that it's not plug and play where you just acquire data and just feed it in, and you have to have an extremely competent optometrist, good analysis, get relevant topographic maps to use to get optimal outcomes.
Professor Bellin?
Two questions or comments. First to Brad, because our software may be very different to what you have access for Contura, and I do Contura, so it's nothing. When a patient comes in, how do they qualify for Contura?
Yeah, well, based on the study, they have to be normal.
Okay,
that's the
many
problem in the United States, is that they had to have been normal in order to qualify for the study, and therefore the study is approved for normalized that probably
and
don't
how many
need it.
reproducible maps within a certain range do you have to get?
Well, you have to get 4 that are in agreement, and I would say you have to take 8 to get those 4.
So and I agree, and I do it, nothing negative, so it's a pre-selected population where you've pretty much excluded ocular surface disease and other parameters, irregular astigmatism, where results may not be as good. And a lot of the papers then use Contour results to compare to a historical result, which is all patients, and that's not really a fair comparison.
Yeah.
As far as SMILE goes, again, very low application and utilization in the US. Are you aware of any refractive, high volume refractive surgeon that only has SMILE in their office, not an eczema?
I mainly do SMILE.
Yeah, there are.
Not mainly, no, not
the US?
mainly do SMILE.
No, there's also a cost
No,
factor
no, not in the
here.
US.
No,
Any-
There are a few in India as well
Anywhere.
who do exclusively smile.
So
Smile.
this similar
One
to
in Pune.
that pre-selected patient.
I don't do
Almost every
exclusively
practice that
No,
I'm
there is one
aware
in
of.
Pune.
Okay,
That
almost,
doesn't do only
not you.
no.
okay. Almost every practice that I'm aware of, it's not only SMILE. They have SMILE and they have another laser platform. And we already heard that SMILE has a longer visual rehabilitation. So again, if you're educating your patients to select a procedure, you are again pre-selecting a group of patients who are more tolerant to a longer rehabilitative period and probably have a higher satisfaction index than those that are highly, I want to go back to work tomorrow. I'll tell you, I do my refractive surgery in it's Seattle. It's basically the Silicon Valley of Washington. And if they're not back to work the next day, they're furious. So again, it's an apples and orange comparison, and until someone does a study where they first do Contura, and if you qualify, then randomize them, we will never have the answer.
Yeah, hi. So I've been doing LASIK surgery since 1995, and I've trained about 30 corneal surgeons, 200 residents in LASIK. I started my first SMILE case 5 days ago under the tutelage of Dr. Ganesh and Dr. Brar. I have to tell you, I have been blown away with the results. The last several cases, all of them, day one, checked by me, each eye individually, 20/20 or better, uncorrected. We had a monovision patient, day one, uncorrected, distance 20/30, and what they call N6, which I guess is J2 or J1. Unbelievable. You look at the corneal interface, perfectly clear. Can see the outline of where the lenticle was. Obviously, you see the small incision. And, you know, I have to tell you, I've had superb teachers. That's clearly very, very important. A laser that's completely optimized. But I'm absolutely amazed at the results.
Thank you. I thought we were the only two people who were getting such results. So it is actually a misconception.
No, I mean, it's from a trainee perspective. I thought I have Dr. Pavitra here. She did a first case last week. Just see the case and see that if this, I mean, this independent case, maybe a small addition done. Just hold on. Just see this case and say that is this something, will the result, what she gets, is exactly going to match with one of her seniors get. I mean, this is the first case. It's a very quick one, Pavitra. I mean, we have never had a single video. Thought at least we could play some video. She had a -4 and a 0.75 cylinder, 180 degrees. Dissection of both the planes for people who are not very the anterior and the posterior plane.
High speed, you can see that.
And that's the lenticule. And
you can see that she has marked for cyclotorsion, and I'm happy to see that.
that she gives credit to you. So what what was the, I'm
what
sure
was
you
the
have done your
outcome
own.
on
yes.
day
What was
one?
the
What
what
was
was the
the
first day
vision?
post-op results?
Exactly, I want
Uncorrected
her to
vision.
answer. I have not seen the post.
What was the first day post-op results?
It was 6.
Say it's 2020.
It was
2020.
Each eye.
2020.
Binocularly 6, yeah.
Okay.
Very good.
Uniocular, you should always check uniocular. But what we see is uniocular,
So
most of our
it's
patients,
also
more than 90% of our patients are 20/20 or better.
No, the question is there anything you want to tell her or people like
Yeah,
her?
when you look at the
Please
video,
go
it's,
ahead
it's
and
good,
give some
but I
more.
think the energy can be optimized further, because if you look at the bubble pattern, at the edge there is some amount of OBL, there is some amount of fast OBL, so you can reduce the energy a little more. And we have described
Described a
a
gas
sign
bubble
called the gas bubble escape sign. So as soon as you enter the incision, the interface clears. If you see that sign, you see it in about 60% of patients, then you know that the dissection is going to be very easy and the day one recovery is good. We actually did made a film enhancing the wow factor in SMILE, which got an award at the recent ASCRS, where we describe a lot of things on how you can enhance the wow factor and get 20/20 on day
So
one.
this should get a wow factor.
Yes.
And Dr. Ramurthy, sir, anything you want to say? Because the whole discussion is about quality of vision. He
See,
got
the,
up.
the other thing, Rohit, she does not need to do 200 cases. She can get 20/20 on day one because you have gone through that process of
She has
and
observed
seen
you.
so many and
She has
optimizing
observed
and learned how to dissect and you have passed it on to her.
But there are times, the challenge here is, there are times that somebody who's already doing a cataract and he wants to get into, or retina surgeon wants to buy a machine, then he has no time to spend a year or two
Not
learning.
a year. You don't need to.
So basically, the take-home point is that you have to learn from the best,
You
wherever
have
it
to,
is.
yes. You have to learn how to
Rohit,
optimize
I'm
your
talking
energy,
about
get your
an
normal.
average surgeon who's practicing and also is starting, okay? He needs a platform wherein there are not many variables.
But you have more
Across.
variables in Contura. Planning, you have a lot of variables. How are you going to decide?
I think
that also needs training.
We keep having this discussion about phaco versus femto. Now it's become something like this: SMILE versus Contura, SMILE versus femto, in the sense that we should acknowledge this, both these technologies are complementary, and they do give good results. And definitely, when I have faced with a difficult case, irregular cornea, they have no choice but to use a femtosecond platform. And astigmatism, yes, Contura works extremely well if you are able to get good maps. But as far as simple garden variety cases, refractive errors are concerned, the comfort level of the patient, day one post-operative vision, the flapless surgery, SMILE is definitely scores over it.
So in which patient, sir, would you choose Contura over SMILE? Since you're mentioning that they are all complementary to each other and they're not necessarily one over the other. So if you can give some examples where you would prefer Contura over SMILE.
As was mentioned, Contura was technically supposed to be used on so-called normal eyes with correction of the minimal higher order aberrations on the anterior surface of the cornea. But now the concept is also there that if there is a TMR, topography modified refraction, where there is a difference between the subjective acceptance and what you get, the astigmatism through the topography, you go with the TMR values, and those are the patients who are likely to benefit the most.
No, do you go more with the subjective or with the topography?
With the topography modified refraction. But when we did this for a few cases as a part of a study, our results were not very satisfactory. So now actually just doing a modified form where it's called Forcidase, where we are taking into consideration the internal aberrations, the posterior corneal astigmatism, the anterior cornea, and the subjective refraction.
I want to
we have
answer
just had
one
12
question
eyes
about this, because this is related. I think I would like you to answer again. So in today's world, how strong is the marketing in the delivery of a product?
I think there we have to accept defeat because Alcon definitely is better at marketing than Zeiss.
Marketing is much better.
If you think of intralays, I was associated with intralays at the very beginning, and I never thought a macrokeratome at a cost of $500,000 would replace a microkeratome at a cost of less than $100,000. But the marketing of intralays was fantastic. And then once one had one in one clinic, oh, they've got a laser down the street, so you've got to have it. So I think marketing here is incredibly important, and the way it's done. And for example, in my country, Dan Reinstein has been doing an amazing job to market Smile. More fields, on the other hand, have looked at the, statistics at that time and said at the moment we won't go there. So marketing is going to be very important. So can I just add one more thing to the discussion here? You know, as a scientist, anecdotes blow my mind. One case, another case, 2 cases, 3 cases. The literature has tens of thousands of cases of LASIK that we haven't even touched on, and it's growing hundreds to thousand cases of Smile. So ultimately, you as the final arbiters either have to decide on the basis of numbers and statistics in the literature, or who you're going to trust amongst the characters, or which company does the best marketing. So again, there are a number of different issues here, and you've hit the right one there.
If you can read this, even when you look at any advertisement of any watch, whether it's Rolex to any of your fancy Swiss watches, the time which always set is 10:10, because they have been told that 10:10 is a happy face, it's a smiling face.
Rohit, if you're in Switzerland on a railway station waiting for a train and the train isn't there, there are 2 alternatives. 1, it isn't a Swiss train. 2, it isn't a Swiss watch.
Dr. Abhijit, if you can
So
just
I just
give
want
a comment.